just as an opinion, why the doctors I've spoken to outside of you, it's novel to the psychiatric field, but it's not necessarily like new medicine. It's a lot of fundamentals.
Right.
Why? There's probably a lot of opinions on this, but
There's a lot of opinions.
why is this not a standard of care today? With this podcast, what we're trying to do is have real, authentic discourse. Dr. Miller, it's good to have you this morning.
Good to be here. Thanks for the invite.
Absolutely. Known you for a number of years. Always enjoy spending time with you. Really excited to have you as a guest today on our podcast. And I think I had mentioned it to you that Enterhealth was going to be doing a podcast this year, Treatment Redefined. And the main objective of it is to have some influential thought leaders around the treatment field, really addiction, mental health treatment. You've been pretty influential with us over the years. You also practice your craft in other areas of kind of behavioral health. So really excited to have you here today. And I thought maybe just a way to open this up is let's just give people a feel for your background and some of your training. Just, kind of casually just tell people, what you're about.
Sure. Well, I'm a board-certified neurologist by trade. This journey of treating, brain disorders, maybe a little bit off the beaten path, kind of different than what usual medications and imaging and things like that kind of came to me through the military when I was treating our soldiers, our airmen coming back from wars and battles with traumatic brain injury. And that's kind of a good intro to what's going on with the brain is when you come back with a brain that isn't operating as it once did. And that began kind of the journey of how can we actually treat these conditions. Over time, I've been introduced by other greats in the field to technology like MeRT, magnetic E-resonance therapy, which you and I will talk about today, which also you and I use in our respective practices. And other treatment for brain disorder that sometimes people have not considered that can actually activate and optimize brain function. And so my journey for the past 14 years has been finding ways to wake up sleeping brains, activate dormant tissue, and optimizing function of brain that is suboptimal. So I use the term. I think there's a variety of terms in this, and we'll get into some of these as we go through this. But I kind of look at this space as neuromodulation. Would you agree with that? Exactly. Yeah, absolutely.
And so in your practice, you're a neurologist. Have you always been in the neuromodulation space, or is this something that you've kind of worked yourself towards?
Sure. This is something I've worked myself into over the years. I would say I started Brain Treatment Center Dallas about 6 years ago, where we introduced MeRT to Texas market. And we started out treating almost exclusively autism and some brain traumas, depression. The technology itself that we're using has been around for 24, 25 years. We've modified the technology to improve on very high-functioning, very specific types of brains. And so it's something that kind of fell in my lap here in Dallas, which I'm so glad it did. I have not pivoted from it since, and we're just trying to find better ways to use it.
Yep. So I think just to bring people up to speed, we've probably known each other 5 to 6 years now.
That's right.
I believe. Enterhealth got introduced to MeRT back in, I'd say, probably 2019-ish, 2018, 19.
Right.
Doctor that works with us, Dr. Ralph Roshbaum, dear friend, known him for many years. My family's known him. He's one of the co-founders of Texas Back Institute. And he had met the people that were behind MeRT, Wave Neuro.
Right.
Might have been called something different back in the day. And he went to breakfast with Dr. Roshbaum, and he said, listen, Dave, you need to keep an eye on what these guys are doing. There might be some real application in your space of addiction and mental health. So Dr. Urschel, one of our co-founders in Enterhealth, he and I flew out to San Diego area, spent about a week out there, met with Eric Wan, met with some of their leading researchers, and I was really blown away. One, by the professionalism of the group, but also just the type of work that they were doing. So correct me if I'm wrong, but that group really got a lot of their, kind of origins was working with Special Operations Command, working with, veterans that were coming back, people that had PTSD,
That's right.
a variety of issues. And by using these protocols, which we'll get into kind of how this works with TMS versus MeRT and how you're using the machine versus the protocol. But it seemed to me that they had a recipe, if you will. Their protocol was very effective at alleviating PTSD, anxiety, sleep with a lot of the people they were working with. And so at the end of the week, I was convinced, so was Dr. Urschel, that this is exactly what our population deals with. Now, we're dealing with a patient base that suffers with substance abuse, addiction, but there's always something under that that's really fueling it. And most of our patients have tremendous issues with sleep, anxiety. There is some PTSD with a number of patients, but we felt like bringing this in, and we did a trial for about 60 days, and we basically, right after the end of the 60 days, said we're going full bore into this because the patients were getting such amazing symptom relief.
That's right.
And it's actually been a real blessing to be able to bring it in. But I was wondering from your perspective, like, what is it that, let's kind of get into, what are we talking about here? Because I notice when I bring this up, there's TMS, then there's MeRT, and I'm not a clinical person, but I look at it as the TMS is like the machine, if you will.
Right.
But MeRT is really the proprietary protocol that's utilizing this machine. But maybe just give people a feel for, what are we talking about here? What are we trying to achieve by using this technology?
Sure. So exactly as you said, TMS, transcranial magnetostimulation, has been around for 25 years. It's in research and finally has FDA approval for conditions like depression, OCD. It's rapidly gaining traction with addiction, with anxiety, traumatic brain injury, and particularly PTSD. We're currently in the midst of a multi-site, multi-year double-blind sham-controlled study for PTSD as well. What's fascinating about the first statement you said was we first started with the special operations, or Wave Neuroscience started treating special operations. They received funding from the military, from the special operations forces as well, to be able to treat soldiers coming back from really, really significant battles and wars and coming back with traumas and suicidality and just all the things that you're also dealing with at your own clinic, the same things I'm dealing with at my clinic. And they treated them with this technology that initially was TMS, but realized that a lot of these special operations brains actually were operating much faster than the standard human. TMS was FDA approved for a very specific frequency for the average human brain, between 9.6 and 10 hertz, which on the earth, the average human frequency, or how fast the brain is operating in its normal or optimal function, is about 9.6 to 10.
How do you measure that? Like, how do you get that initial measurement?
Right.
What is like the tool that you're using?
We use a QEEG, quantitative electroencephalogram, and that is a standard protocol, standard EEG that's been done for years that we've modified again to recognize frequencies in the background. Like alpha frequency is the frequency that is when you're awake and when you're concentrating or focusing or just in your usual, you and I right now are in our alpha states. That's just our calm, collected, restorative brain health state. And so several investigators who realized that there were EEG signals in our special operations that were much faster, or should have been much faster, would come back from battle and were operating much slower. And so we were able to modify, or they were able to modify, the initial protocol at 10 hertz to exactly the frequency of their optimal, or the special operations soldiers and people in the military as their actual personalized frequency. And so that personalized frequency is what makes MeRT different from TMS, in that we can measure everybody's brain function with a QEEG. It takes 10 to 20 minutes. And analyze the data from just a standard EEG, turning it into a quantitative EEG, determining frequency, where the brain should be operating at its optimal function. And we can then program TMS to a different frequency that's similar to or exactly the same as within 0.1% margin of their optimal brain function, and treat them at that frequency.
So do we each have kind of our own optimal frequency?
We all
should
have
fire
our
out. So like if you and I sat down, we both would have maybe an optimal range, and then from there you can tell where we currently are. So there's usually a delta there, I guess, between where you're at and where you should be.
That's right. Everybody has an optimal alpha. There's multiple different names for it: posterior dominant rhythm, intrinsic alpha frequency. It's where your brain should operate when you don't have drug addiction, traumatic brain injury, depression, medications, substances, so on and so forth. And that is always measurable on an EEG. It's very rare that we can't see a semblance or even a small portion of the remnant of the alpha, the intrinsic alpha, present on an EEG. For instance, in a traumatic brain injury, you are generally seeing a brain that has completely slowed down. The whole cortex is not operating optimally after a trauma, even a mild traumatic brain injury. And you can see that there's several portions of the brain or multiple networks that are operating at a much slower frequency, but there's always a signal on the EEG that shows where the brain should be operating. Our goal with MeRT is not to treat the standard brain, but to bring the brain back to where it should be operating, which again is what we call the intrinsic alpha frequency. When we started researching traumatic brain injury, we realized there were markers for addiction, depression, anxiety, OCD, PTSD, and the list just goes on and on. Any brain disorder you can list, you can almost see a characteristic in the EEG and figure out how to optimize brain function from that. So for your world and what we're talking about for addiction and mental health, again, biomarkers in the QEEG are now visible, and where the brain should operate is understandable. When you marry those two together, you have a technology now that can actually modulate the brain to its optimal function. It works well together.
What I find so interesting about this use of this technology is it's trying, in our space, we're dealing with a lot of anxiety, generalized depression. We're trying to treat this differently than just the use of medications. And I found over time it's not necessarily either one or the other, but sometimes the combination of the two can be highly effective. But this is attacking a similar symptom. But it's not using medications to do this. It's really, is this electrical circuitry of the brain that you're really affecting?
Well, I mean, going back to the very basics of what the brain does, the EEG measures the electrical output of the brain. The brain is constantly looking for an equilibrium, an electrical equilibrium. That electrical equilibrium or its optimal function actually will influence neurotransmitters, hormones, and the way the vasculature of the brain works. So all of this working in tandem, medications, cognitive behavioral therapy, and all of those other kind of additives to MeRT, or if you want to look at MeRT as an additive to those, they all work well together because all of those have to be in balance for the brain to be completely optimal. And so medication along with MeRT or cognitive behavioral therapy along with MeRT have sometimes a better effect than just MeRT alone. What's nice about MeRT, the electrical signals, when the electrical signals are mainly or primarily the problem, which quite honestly, traumatic brain injury, sometimes some forms of depression, some forms of PTSD, and some forms of addiction are literally an electrical aberrancy or an abnormality. And to simply just fix that by neuromodulation, by MeRT, you don't need medications. You don't need other forms of therapy. In general, having the full support system makes the results better, last longer, more robust, and more lasting, more meaningful to the patient. So it's always good to have the whole picture, but it's nice to see that we have a modality that is non-invasive, non-medication, non-surgical, and has very little downside to it.
Okay. So when I'm talking to people about this, sometimes they'll say, well, I've had TMS before. And I'll often say, kind of in lay speak, if you will, that this is really personalized form of TMS.
Right.
And Dr. Urschel would always say, look, it's like going to a shoe store. If you're looking for a size 9.5, and the TMS machine's a 9, then you're going to it could be effective for you. But if you're a size 11, it might have diminishing returns.
Right.
Just give me a feel for what are we talking about here? How's that? What do we mean when we talk about things like that?
Sure. So if you're a size 11 foot, if you're using the same analogy, and you put on a size 9, you could probably get your foot and your toes in there, but walking for any given period of time would not feel great, right? It's suboptimal. Putting on a size 11 if you're a size 11, 11.5 if you're 11.5, feels better, is better for your feet, makes you walk better, run better, whatever. Your performance will be better. It's the same thing with our brain health. It's actually more important in our brain health. Adjusting the brain toward its equilibrium, its optimization, is more important than probably any other aspect of the treatment. It's not just treating a brain, it's treating a brain accurately to its optimal function. So
moving it towards its optimal function is where you're going to probably get the most symptom relief and maybe sustainable types of results as well?
That's right. The closer you are to adjusting the brain toward the optimal or toward its intrinsic alpha, the more likely it is that it'll last, the more likely it is the patient will recognize the changes. That's just as important. And the more likelihood of resolving the issue for which they came in, depression, addiction, things of that nature.
So what types of issues are you seeing? What are you treating? What are people coming to see you for?
Sure. The majority of the you're talking about in private practice, Brain Treatment Center Dallas, Brain Treatment Center Plano mainly see autism. Probably a majority is autism. We're starting to slowly see the growth of depression through partners like yourself, PTSD, anxiety. All of these are off-label other than major depressive disorder, so we're always happy to see the on-label major depression. But the majority of what we're doing now is off-label in autism. In my other practice, Neuroperformance and Injury Center, which we're also partnered with, we're treating exclusively traumatic brain injury. The nice thing about traumatic brain injury, just like in addiction, is the comorbidities that come with traumatic brain injury generally are anxiety, depression, headaches, PTSD, addictions, worsening of any neurologic condition or worsening of any psychiatric condition. You add this to the mix, and all of a sudden you've got a person who may have had medication or treatment before, but now all of a sudden the broken part of the body, the brain itself, is now being healed. So it's a game changer for you and for me in all of our endeavors.
It is. One of the questions I get quite a bit and our staff gets is this sustainable? Give us a feel for what are we talking treatment-wise? And I know that's evolving too, as there's probably newer protocols or newer evidence coming up that you might be able to have maybe reduced days or sessions, but maybe just give people a feel for what are we talking about? Like, what is a course of treatment? Sure. What is a recommended course of treatment? And then, in your mind, are these results sustainable, or is it something that after 6 months or 9 months or 2 months that you feel like you kind of regress back to where you were, or does this stick?
For the vast majority of patients, let's just use depression. 6 weeks of treatment, 6 to 8 weeks of treatment, which is 30 to 40 treatments, will usually be the average or the recommended dosing or timing of the protocol. The lastability or the duration of the treatment is variable, but generally is quite long-lasting. There are people who will jumpstart their brain, if you will, what we call jumpstart the brain, will activate or optimize it, and we'll never see them again, never need them to see them again. There are people, and probably 10 to 20% of patients will need maintenance therapy. And maintenance therapy is very simple. It's outpatient. Again, it's more along the lines of 10 treatments, which is 2 weeks. Each treatment lasting 15 to 40 minutes, depending on which protocol you use. There are, so that would be the standard therapy. There are newer protocols coming out, including what we call condensed MeRT, which is a 15-minute protocol, which is also a game changer. It's less rest between treatment trains. It takes 15 minutes in and out of clinic, and it's still 6 or 8 weeks of treatment is optimal. There are SAINT protocols, which are FDA approved for rapid improvement of depression with suicidality, and that's 10 treatments a day in a very, very controlled setting. And there's between those two, there's a variation or a host of variations that are able to be used for certain conditions.
So you're using essentially the same technology, the same machine. You're just using a different protocol or application
That's
of it.
correct. That's correct.
So in your mind, in the SAINT protocol in our space, using MeRT, what are you seeing as, do they both apply, or is one maybe for a more acute type state? And, because as you've worked with us, you've seen our patients are really looking for true treatment. They've often tried a number of things, and usually pretty high-functioning individuals, by the way. They just have an issue with substance abuse that's taking them to a point where they can't really function at home, they can't function at work, they're having difficulty in life. When they come to us, we've always tried to bring everything that we believe is credible and relevant and research back to bear. And allow our patients to have access to that. And they stay a period of time. And so I've wondered, human nature is, can I do this more quickly? Can I do it shorter? Does it need to take as long? Where is this kind of heading in your mind with, right now we feel like the standard protocol, I believe, is we do about 30 sessions, I think, on campus.
That's right.
Is that moving to a shorter application for us, or is that where it should be?
Probably in the end, because of a process called neuroplasticity. Neuroplasticity is the process by which our brain learns new techniques or new protocols or kind of new function or returns to previous function that is optimal. And so neuroplasticity is very important. It takes time, just like with a diet, to reset your mind for a diet doesn't happen in 2 days. It takes 6 weeks or 5 or 6 weeks, according to, depending on who you're talking to. The same thing with MeRT or neuromodulation generally requires a good 5 or 6 weeks for it to really stick, to really be in a state of neuroplasticity. It requires repetitive treatment. We are noticing with this technology that it amplifies or expedites the process of neuroplasticity. And so what we're working with now is shorter protocols like the SAINT protocol or even 2 times a day of treatment or 3 times a day treatment to see if the same number of treatments will actually yield the long-lasting effects that 6 weeks of treatment would yield. So the jury is still out a little bit on that. It's becoming much more common. There's certain protocols that treat much faster called like theta stimulation that are really, really short, condensed protocols of TMS. And their lastability doesn't seem to be as long as the standard, even condensed or standard MeRT over 6 weeks. So for now, that's kind of the recommendation. That's actually is the recommendation for about 6 weeks of treatment, just because we want it to stick, to last, to really optimize the brain. Over that amount of time also, we are able to get multiple QEEGs, multiple studies that help us determine if what we're doing, in fact, is optimizing brain function. So we can pivot a little bit with a frequency or a location of treatment to make sure that along the journey of 6 weeks or 30 treatments, we actually get the optimal outcome.
So on that note, just kind of going back to the application, we're talking about you're using a magnet. Are you moving it around as the treatment goes?
So generally, we will treat at a certain location depending on what's most aberrant, what's most abnormal. In general, we have learned that activating both sides of the brain, which means treating right in the center of the front of the brain, seems to have the best effect, particularly when you're focusing on the intrinsic alpha frequency, so each person's individual brain markers or speed. And so we have noticed over time that seems to be better than targeting one side for activation and one side for deactivation. There's lots of research going on with standard TMS in those domains where you can activate one side of the brain, deactivate, or use a faster frequency here and a slower frequency there. But it doesn't seem to pan out better than MeRT itself.
So, curious question. Do you have to have a issue, like a presentable issue, to say, listen, I think I've got something that I'm dealing with. I can't quite figure this out. I'm going to go seek Enterhealth or Dr. Miller out and engage in neuromodulation? Or could you take me, could you take other people, sit us down and run a QEEG on us and see most likely some deficits that are just normal in life as you go through life? I'm just kind of curious, what would in your estimation, what would like the broad swath of the population see if you took 200 people that weren't necessarily seeking treatment and did QEEGs on them?
I think, especially in the world of COVID, we're finding people who didn't even know they had symptomatic COVID or didn't have symptomatic COVID who still have the brain marker, right? We're starting to recognize there's a biomarker, which is very similar to traumatic brain injury for people who have had COVID or were even exposed to it. The question mark is the vaccination causing the same signal? We don't know that yet. But we do know that there is an abnormality generally frontally. So the executive function, the motor function, the language function, the brain function that as, hi, I'm Spencer Miller, my frontal lobes are operating this way. That is what's most affected by COVID. Your brain heals after having COVID, but there's markers throughout the brain that and it's usually a different frequency than is your optimal frequency that is causing people to have anxiety, cognitive fog, which we call COVID fog or COVID brain, new psychiatric disorders, including OCD and ADHD, attention deficit especially. So, anybody who comes in, there are people who come in and have a perfect EEG and just want to see what their brain's doing. Nobody has a perfect EEG, but one that doesn't necessarily have a marker that I would say, oh, you need treatment, or I can identify this type of condition. Even those folks who have an EEG that just has a perfect alpha, they're all synchronized, aligned from the front all the way to the back of the brain, still have tune-up capability. If you think about an orchestra, a really, really fine orchestra, the orchestra or a symphony does not walk in the New York Met and they're all perfectly stringed up and they're all harmonized and ready, and the conductor can just come in and start playing. They have to tune their instruments along with each other all the way along the way. Our brain is exactly the same way. If the sun is a certain way, if the temperature is a certain way, if your coffee wasn't just right, if whatever condition somebody's stressing you out, your instruments are not perfectly tuned. And so there are times when that can be so pervasive that you need a tune-up. And so people coming in, we call this optimization. I guess in an orchestra setting, it would be kind of tuning the whole band together, or the whole orchestra together, so they could actually play a beautiful harmony. And when the conductor comes up and hits and strikes his conducting pad, all of a sudden everybody's already well tuned to A, and it sounds beautiful and it's comfortable. Well, the brain is the same way. When there's one instrument off, if the string section were sharp, you would notice that it would feel uncomfortable to an audience, especially to a conductor, to hear that. When the brain is sharp, or when the brain is just slightly off, it's enough. It doesn't take much to where somebody will notice difficulty making decisions, or difficulty with memory, or difficulty relating to their husband or wife, or whatever we do on a daily basis can be just slightly off, and sometimes people don't even recognize it. You describe sometimes abnormalities on an EEG to a patient when, for instance, I see two peaks. If I see a split peak, oftentimes people have trouble landing on a decision, or making decisions as fast as they once did, or concentrating in a meeting. And when the patient kind of sits back and thinks about the past 3 or 4 weeks and what I can determine and decipher from an EEG, all of a sudden things become apparent. My instruments aren't tuned to each other, and optimization tunes the machines together.
Yeah, I'm listening to you and I'm thinking through just the evolution of, like, say, psychiatry, which is a part of our treatment. So, dealing with the underlying psychiatric issues is essential to being able to treat addiction and mental health effectively. But it feels like, and I've mentioned this with other guests, that I feel like we're moving a little bit into a new frontier in terms of psychiatry, where we're getting away, not really getting away, but we're adding to, I guess, if you will, just, subjective symptom diagnostics, which I don't really do any blood draws. We'll talk about that here in a minute. I don't really do a lot of objective diagnostics, to where we're moving into, if we believe that addiction and mental health is centralized in the brain, although it does interrelate with the body completely. I want to hit on that here shortly with you. But having some objective diagnostics seems to be essential. And one of the things I've found is that when patients come through, when we can present to them the QEEG, it is objective criteria showing, look, this is what's going on in your brain. This could explain a lot of the symptoms.
Right.
And then, what I found super interesting over the last 6 or 7 years is the number of patients that have gone through the MeRT protocol with us, maybe 270 plus in the last 6 or 7 years. Maybe 2 have opted out, and most of those 2 really had nothing to do with them not wanting to complete it. It was a health-related issue that made them actually opt out. So and to me, that's indicative of the fact that they feel the relief. Right. They know it's working. By showing objective criteria in the beginning, delivering a course of treatment, and feeling symptom relief, that seems to be where we should be heading with psychiatric care, should it not?
Absolutely. With addiction in particular, I have the luxury of following up some of your outpatients through the MeRT protocol. And one of the things that's different, a lot of the patients, the high-functioning patients that are drawn to Enterhealth and the techniques you use for addiction rehab are very highly functional brains, right? They're CEOs, and not everybody, but the ones that come through are recognizing that something has changed as compared to the 15 other times that they may have been to another rehab facility and not had MeRT. And so when you add MeRT to the mix, number one, in general, cravings, which is something that's very challenging as you leave rehab, you all of a sudden become your own person. You're now controlling your world, and cravings become an issue for people who have been addicted before. And to have a reduction or complete resolution of addiction cravings, or cravings for the addicted substance, is quite remarkable. I hear that from the vast majority of our mutual patients. The brain function, somebody who has an addiction, right, has caused a trauma to their brain. It has actually slowed down the function of parts of their brain. And even though some people will say, no, I operate better on this substance, or I feel like I'm a better person, or I feel like my business meetings are better if I'm slightly inebriated, or whatever, I've heard it all. All of a sudden we'll leave rehab after MeRT and have maybe maintenance MeRT or other therapies where all of a sudden they realize that their brain is optimally functioning. They're better in meetings without the substances, which is a huge win for them, because if you have that mentality of, I went back to my meetings after rehab, I no longer have the drug in my system, but I don't feel like I'm optimally, running a meeting or running my company well, then all of a sudden the first thing that happens is, well, I needed just a little bit of that. And once that little bit comes back into it, the game is over for them in general. So
the brain's a pretty remarkable organ in the body. I feel like it's a little bit of the last frontier. We're discovering so much about it,
right,
and know so little, but we're learning so much at a rapid rate. If patients that have had substance abuse issues come through our program and just refrain from using, is there a neuroplasticity? Is there a regenerative is there a healing process that will happen naturally, and MeRT just accelerates it? Is there a limit? I'm trying to get a feel for work. If you just don't use the substances, will you have some natural healing to a point?
There will be a point of natural healing, but there is a marker. For instance, alcohol leaves an actual trace, a slow frequency in the brain that is a comfort for the brain when you add the substance. Having alcohol in a brain that has what we call the alcohol peak, oftentimes it actually makes their brain feel calmer. It makes them feel like they're in a better state, even though they're not, and people around them can tell they're not. They don't know that, right? You only know what your brain tells you. Unfortunately, sometimes we have to be, friends have to tell us, or
right,
doctors have to tell us, hey, something's going on that you might not recognize it, or colleagues, or employees. But without having something like MeRT, some sort of neuromodulation, it's very unlikely that the brain will fully heal. It can heal enough, right? There's been people going through rehab for decades, right, without having to go back to their substance. But there will always be that pattern in their brain where that substance will always be a comfort to their brain, right? It'll allow the brain to slow down to a peak. And when the brain finds a peak, it's comfortable there. Your goal with neuromodulation is to eliminate, or at least to reduce that peak to a point where it's not recognizable. And so people who are post-MeRT, post-rehab for, let's say, alcohol, if there is a dabbling in it in the future, it happens, right? So if there's a dabbling in the future, it doesn't bring the brain back to a comfortable state. It immediately tells the brain something's wrong. Like you and I, if we drink alcohol and go to a meeting, it's not going to go well. For me anyway. I know that my brain is not meant for that. Right? It slows down my brain. It makes it very difficult for me to concentrate, to focus, to have good things to say. It's hard enough without alcohol as we get older, right? So imagine, having lost that peak that their brain is used to achieving, all of a sudden you put alcohol in the system and it's no longer comfortable. It doesn't make the alcohol taste differently, doesn't make it look differently, doesn't make it have a different effect on the body. The brain is no longer feeling comfortable on that substance.
So when you've had a number of our patients over the years that you've looked at and helped treat, are there some unique characteristics that you've seen in substance abuse addiction patients compared to the other population?
Yes.
Like, have you noticed any just repetitive cycles or some patterns that have evolved over the years?
It's very relieving to the patient. First of all, many of the really high functional patients, the very, very, highly functional / addicted patients, oftentimes something major has to happen for them to recognize there's a problem. When I see the patients after Enterhealth, particularly the MeRT, post-MeRT, post-Enterhealth rehab sessions, the patients oftentimes we'll describe being relieved when they see an EEG and objective data to explain what's going on in their brain. And then as they see the pattern improve with MeRT, or they see the changes, and we can explain what to expect based on their last result, their last EEG after treatment, all of a sudden there is a ability of that patient to self-recognize, to self-analyze, and to make sure that let's just say they're still slower than their average or something after even 6 weeks of MeRT. Sometimes people are not at their optimal. So imagine if they're slightly slower and they know it. That we've jump-started the brain. We've modulated that intrinsic alpha frequency. It will improve over time even after MeRT is done. The brain is always looking for its intrinsic alpha, always looking to be optimized. And without a substance to continue to bathe the brain and make the brain work less optimally, the brain will continue to heal. So it gives it an opportunity to continue to heal on its own. With substances, along with post-MeRT and post any kind of rehab, if the substance comes back in, you're damaging the brain again, which requires treatment again. So the fact that the patients will leave and will have this different mentality of, I don't feel like I need the substance. I feel like I recognize my brain is in a better state. It's less likely, much less likely, that we'll have them return to rehab with that addiction again. I can't remember a patient that you and I have shared, and I am sure you have better statistics, but I can't recall a patient that has come through my clinic twice from Enterhealth, which is remarkable because we have seen other post-rehab patients that, I went back, I went back there because I needed the substance again. And, we treat them post rehab.
Yep.
It's different when you're in the midst of it. I know there is a benefit to having cognitive behavioral therapy and support during the treatment. We know from other modalities that concomitant treatment with cognitive behavioral therapy and MeRT is significantly more effective for healing the brain. The brain is very suggestible with just even talking, thinking, feeling, and understanding and believing that it's going to get better. And in the rehab setting, to have that, including sometimes medications, but then MeRT on top of it, you put those together, it's absolutely a game changer in the addiction space.
Yeah, I think so too. I've always been, and you and I have talked about this over the years, I've always been a big believer, particularly for the patient base that we serve, is that time and treatment is really, really important. It's something that's hard to, shortcut.
Right.
Shortcut treatment, 5 days in detox, straight to outpatient. It might work for insurance reimbursement, but it does not work for what patient care, what patients need. And an interesting little thing that I've noticed is, as we've treated these patients with MeRT, there is a little bit of a period of time. I may be off on this, but it's like the treatments will begin, but then there's almost like a little bit of a reset, or maybe a couple of few days where maybe the symptoms are a little exacerbated, and then it kind of settles.
Sure.
And I've always felt, and you correct me if I'm wrong on that, but I felt like being in a residential setting, being able to get the MeRT treatments and go through that kind of difficult period, if you will, where maybe there's a couple of days where your just symptoms are really exacerbated. You're in a controlled setting, if you will, surrounded by all the support that you need to kind of work through that and then continue the care. Have you noticed that there's like just a little bit of a period of time where maybe the brain's almost reorganizing a little bit before it fully optimizes?
Yep. It's routine counseling for a patient, for me to talk to a patient about the first 4 or 5 days of treatment. When you have the first 4 or 5 days of MeRT, again, we're causing the brain, we're activating the brain to function in a way that it's supposed to operate but has not been operating. And that delta, if you will, that change in what is happening and what should be happening, that transition to optimization is really, really palpable. You can feel it. You generally will have a little bit of trouble sleeping at night. The mood is usually very high or very low, and it fluctuates. It's not quite bipolar levels or suicidal, manic, anything like that, but it's enough to really throw off your day for some people. Not everybody. Most people, it's very ginger, it's very mild, but in the setting of addiction and in this the setting especially of depression, to have that controlled environment is very, very essential. Because, again, if you get to a depth of depression with newfound energy from MeRT, because MeRT does energize the body, it energizes the brain, but if you have that depth of depression and suicidality, you need to be in a controlled setting. It's very, very important.
I agree. And being able to control cravings in the patient population that we serve is so important, because that is often, that's the trigger to going and using, is to get that symptom relief. So being able to kind of work through that is really, really important. One key thing that you and I have talked about over the last probably 2 or 3 years, and I really sought a lot of your counsel on this, and we're now bringing it to life, is this area of functional psychiatry.
Right.
And, I find it so interesting to talk to you about it, because being a neurologist, you're really an expert and a doctor of the brain. And when you start looking at functional psychiatry, we're broadening the scope of what might actually impact symptoms or psychiatric symptoms within the brain.
Right.
And I've been fascinated with this area. I think it's evolving. I want to get some of your opinion on this today. But it's really the idea that your unique biochemistry, how it interrelates with your brain, there is a correlation there. And being able to understand what's going on with maybe gut health or certain unique blood markers, being able to really understand, because there's probably hundreds upon hundreds of different blood panels you could look at.
Right.
But understanding which ones are important and how they directly relate to someone's emotional well-being and why they feel the way they do, I think that's a little bit of the competence and the art of it. But we're trying to, and are doing it right now, applying this in our treatments in 2025. And I feel like it's going to be a game changer because it's opening up avenues of treatments that people that have suffered with psychiatric symptoms have never really had access to. I don't know the last time I've heard of somebody going to a psychiatrist, for instance. Maybe they've got anxiety, depression, or just addiction treatment in general, and somebody running a series of blood panels on them, 250 different biomarkers, and how they all interrelate and why they might be directly correlated to the way you feel. I'm kind of curious your opinion on this field, because I've sought your counsel on it, but also where does MeRT and neuromodulation fit in? Because in my mind, neuromodulation tucks in real nicely with the whole functional approach to treatment.
So if you think of the brain, this is a very good question actually. If you think of the brain as just its essential role is to utilize energy appropriately, electricity, if you will, or energy in the source of electricity to function properly, to feel good, to be able to maintain an intrinsic alpha that is healthy. When you have the brain using its electrical power or the amount of energy that you put into your body to be optimal, you don't have pathology like depression, anxiety, OCD, PTSD, et cetera, et cetera. You don't have cognitive fog. You don't have the deficits from any other neurologic or psychiatric condition. The gateway to getting energy to the brain is your gut.
That's right.
And the gateway to figuring out what is wrong with your brain is figuring out sometimes what's wrong with the gut, finding out what energy source is missing, and replacing that energy source, or replacing what the body is having to process through to utilizing that energy that could be diverted to brain health, but instead is using its energy to process inflammatory conditions, which what you put into your mouth very much affects whether your body and your brain, again, 100%. Is in some sort of an inflammatory state or not. Whether you're providing it with good energy or if it's quick energy, sugars, for instance, are a real quick hit of energy, but then a really huge crash. So are you getting enough protein to really actually maintain the energy of the body and the function of the brain? The brain takes an exorbitant amount of energy to maintain it in a normal, functioning, optimal state. Any aberrancy in what you put into your mouth, anything that you put in your mouth that isn't optimizing even energy to the body, again, sugars, gluten, casein, soy, a host of other things, or anything that diverts the attention of the body to digest healthy substances, takes away energy from your brain. Mm-hmm. And so if you look at it in the spectrum of optimizing what we put in our mouth, which is what functional medicine is, looking for root causes, generally in the form of supplements, nutrition, sometimes genetics. Right. But functional psychiatry or functional medicine in general is novel in the sense that, and it's growing very quickly, in the sense that it's looking for, if somebody has a thyroid disorder, it's the cause of the thyroid disorder is not lack thyroid. It is something that is causing the thyroid gland not to produce enough T4, go. T3, whatever. So what's the root cause?
There you go.
Not what medicine can fix the broken thyroid. What is it that's causing the thyroid to dysfunction in the first place? And oftentimes you can find that it's simply just a balance of nutrition or a balance of energy. Not always, but a lot of times you can find that as a balance of nutrition. Same thing with depression, anxiety, ADHD, suicidality. Oftentimes is found to be deficiencies of certain B complex vitamins or some sort of inflammatory state that the brain can't seem to operate optimally because it's in an inflamed state. And when the brain is in an inflamed state, oftentimes people feel the effects of it, right? The energy source is used to do something else besides let the brain work as it should.
Yep.
So functional medicine, functional psychiatry is a huge game changer. It is definitely symbiotic with or complementary to neuromodulation or vice versa, however you want to look at it.
They work together though, don't
Absolutely
they?
Work well together. Absolutely.
Yeah.
There's not a better way to maintain a healthy milieu in the brain or a healthy function of the brain without there being a healthy gut.
Right.
The pathways of gut communication to the brain, some will say, are 7 times greater than the pathways that communicate from the brain to the gut. So there's a lot more input from the gut to the brain than there is from the brain to the gut.
That's fascinating.
So it's important.
Just as an opinion, why the doctors I've spoken to outside of you, it's novel to the psychiatric field, but it's not necessarily like new medicine. It's a lot of fundamentals.
Right.
Why? There's probably a lot of opinions on this. But
There's a lot of opinions.
Why is this not a standard of care today?
I think a lot of our education as physicians is what does the FDA say, what's FDA approved, and a lot of what I do is off-label from the FDA. It's not against the FDA, it's not wrong, it just simply doesn't have an FDA approval. That does not necessarily mean that it isn't effective. There's a lot of medications that come out initially for any condition you can name that are FDA pending or approval pending that have tremendous effects. We're in that world right now. We're kind of blazing the trail forward of the future of what is going to heal the body rather than what is something we can use to Band-Aid an already bleeding artery.
Right.
What caused it to, was there a knife or a blade that keeps cutting it that maybe we can remove that will stop it from bleeding again, after we put the Band-Aid on it to fix it? So if you look at it, instead of treating symptoms that are presenting to you at the doctor's appointment, what caused you to have diabetes? What was it? Did we work with you for 10 years to reduce your sugar intake before we started putting you on medications? No, that's not the case. You should, and we know that. Is there a reason why medications, for instance, are not working for your depression? Why is it that every single class of medication doesn't have an effect on your brain when it comes to neurotransmitters? And we find out sometimes that they're lacking in methylation, or they're lacking in a single substrate that isn't allowing the medicines to be metabolized, or even serotonin itself in the body isn't. There's not enough energy to metabolize it properly to reduce the symptoms of depression. So instead of looking at medications as the ultimate source of cure, which there's not a lot of cure for medications, it's really just treating symptoms. How can we go to the underlying source of that? What is the underlying source? And this is these lab panels. There's hundreds of new lab panels coming out every day that will help you with the functional aspects of your body.
That's
inflammation,
exactly right.
Health, mitochondrial function, the energy sources that we take in from food. How does it get to the brain, or is it being effectively metabolized?
That's right. It feels like such common sense to me.
It does feel like
but it feels like there's major forces at play that don't allow patients really to get access to this type of care. I don't know if, just basic physician care, they don't have the time to do the investigation. So if you don't have the time really to spend going through this, and probably, the third rail in a lot of this is there medical necessity for insurance companies to reimburse for these blood panels? And if they won't or can't, then they don't get done on these patients that could really benefit from this. So it just seems like it's good medicine. It's a good way to do care. Hopefully, as we move through this, I'm kind of optimistic. I've talked to a few people, this year about this, just with new administration coming in and kind of looking at a lot of these things. Really the whole, let's look at, it's not really a left or a right issue. We have an issue in our country around people's health, and I think it's a great time to be shining a light on some of these areas. So I feel like there could be a little bit of a tailwind with this, where hopefully some really good discoveries come out of this that can help patients into the future.
We should, this administration may very well bring us into an era of curiosity. We have lost our curiosity, and that curiosity is how great discoveries were made. And the fact that there's now a conversation, I'm on, having treated thousands of autism kids, I'm on a lot of blogs and a lot of websites where mothers are now, the buzzwords are, we're looking for the cause. And when in the last 20 years did you hear anybody who could openly talk about, well, what causes autism, And then also, if we find the cause, generally we'll find, number one, stop the number from growing as it has been, but we'll also be able to find a treatment or a cure.
Okay, so let's hit on that briefly, just because I'm fascinated by it. I saw the recent statistics come out. It's 1 in 31.
Right.
And when I bring that up in kind of inner circles, it's like, well, we've got better diagnostic capabilities. I'm like, well, these diagnostic capabilities must have just become incredible over the last few years. You being an expert in this field, if you were advising our administration and saying, you need to be looking at here and here, because based on my experience and just my life of looking at these things, these are the areas where I really think you're going to probably find some root causes. Where would you go?
So I always, the curiosity in me, I take notes from every mother who comes to me with an autistic child. And I always focus on childhood illnesses like ear infections, but I also focus on vaccination schedule. And I have not met an autistic child whose mother said that they were not vaccinated. So I see autism children, right? My patients are autism, so all of them have been vaccinated. And the questions are not generally, should I vaccinate my kids as they get older? It is how and what schedule do I use? And right now what's coming to light very clearly is are all the vaccines we're receiving necessary? You and I had somewhere around 1/70th of the amount of vaccine volume and numbers.
This is so fascinating you're bringing this up, because I was talking with a lady that I work with in Enterhealth, and we were talking about this issue, and I was kind of went down this similar trail. I was like, listen, I was born in 1976. If I was advising my girls who, God willing, hopefully are able to have the blessing of children, if they were looking at me saying, Dad, what should I do? I almost want to walk into the doctor and say, give them the vaccines I got.
Right.
Everything was just fine.
Right.
So then I just went online, started doing some research, started trying to figure out what are the vaccines and vaccine schedules and how are they different from when I was born to today.
Right.
It's vastly different.
It seems that we know what the vaccines are doing, right? You can measure vaccine program eradication of mumps or measles or rubella or whatever you want to, whichever one of the vaccines you kind of want to look at. And when you have a very good program, it seems like there's a correlate to certain vaccines and reduction or elimination of diseases. What isn't known is what do the vaccines do to our bodies? And so the benefits of vaccines, in my opinion, still are quite great.
Yes.
I might be wrong. There is new research coming out every day that is starting to make me question it. Again, I'm curious, and I like to be curious. I want to know the answers because patients ask me all day long. I want to know what to give them, what information to give them. So I am curious in that regard. I do not have a formed opinion on not vaccine. I'm definitely not anti-vaccine. I think it's very helpful for most of us, and population in general seems that it's been very helpful in the past. And we can, say vaccine eradication. What I'm more concerned with is what information can we glean off of research or from prior research as to what is a possible damage from ingredients in the vaccines. I'm less worried about what the vaccines do. It's what's in the vaccine that I'm concerned with. So I think the contents of the vaccine will probably be analyzed over the next couple of years, and we'll find perhaps better formulations or better ways of making the vaccines last in our bodies. Aluminum is one of those things that are, is a very hot topic. Just to say it right now, this podcast will be canceled. You know what I mean? So,
Right. Exactly.
We're curious. We're not saying that's the cause, and I'm certainly not saying that's the cause of autism. I don't know.
Are you confident that we're going to probably be able to draw some circles around some things that we think are contributing?
Absolutely. I mean, we're one of the things our nation is really good at is keeping really good records in the medical world, right? You get paid to keep good medical records.
Yes.
Medical records are well kept. We can find population-based information over the next couple of years. Somebody has to look for it. And right now, nobody, or before this current administration, it doesn't seem like we were really seeking it or were allowed to seek it. And so I may misunderstand some of the political aspects of vaccines, and that I'm not in politics, but I do know that I'm curious about what is in all the vaccines. What do they do to our body? Is there any literature or research to suggest that there is damage to the body? And if so, what component was doing it? How do we change it? We're extremely creative people. Our bodies are extremely amazing. They're well built, they're well designed, and there is always a second or better solution for current science. And that's what curiosity will find. We should be using our resources to find better vaccinations, better ways to prevent diseases. And in so doing, what we've done in the past, is it what has caused us from going from one person in a village may know somebody who has autism to everybody knows more and more moms every single day who have kids with autism.
That's right.
So our curiosity should be in that.
Yeah, I agree.
And that changes the future. Similar to psychiatric illnesses, our curiosity should not be in, do we understand the receptors? It is, what's causing those receptors or those neurotransmitters to go awry in the first place? And how can we change that without medication? Or maybe medication will always be the answer, and that's fine.
Yep. Well, this has been a great discussion with you. Always enjoy the years that we've had a chance to work together. You're a bright mind, and I love the idea of having somebody that's got the neurological background, that's curious. I think it's an essential ingredient to doing anything important in life. But having you involved with what we do and helping us to move the treatment field forward has really been a blessing. So I thank you so much for being here today, and hopefully we have a few more discussions in the future, and enjoyed our time.
Hopefully we'll find cures for what we're treating right now. Put ourselves out of business. That'll be the goal.
That would be the goal.
So,
thank you.
Thanks for having me.